Hi, I'm Harry Rock, and welcome to another edition of the Westfield Council on Aging Presents. This is a special collaborative effort between Tina Gorman, Executive Director of the Westfield Senior Center, and Pete Coles, producer of WCPC Westfield Cable Channel 15. Our topic today is opioid issues and how a grant-funded program in the emergency department at Bay State Noble Hospital is addressing it. My guest in the studio today, and I'm thrilled to have the three of you. Thank you so much for taking the time to come in out of your busy lives. Jessica Holden, Associate Professor and Executive Director of Nursing and Allied Health at Westfield State University, sitting right here. Sarah Warren at the end of the table, and Heather Colon right over here. Hi, Heather.
Hi.
Project RNs who are the lead emergency department nurses at Bay State Noble Hospital right here in Westfield. So welcome, Jess, Sarah, and Heather. Thanks so much for everything that you're doing for this program. I'm really interested in learning a lot about it myself because I don't know much other than what I've read in the newspapers and hear about the opioid crisis that's going on in the United States. So I think, Jess, you're the head of this whole thing, I take it.
Well, if we're going to talk titles, but it is a joint effort.
Okay.
And I'm the project lead. Yes.
Okay.
It's a joint effort.
We could not do it without Jess. I say this all the time. We cannot do it without Jess.
So with that being said, we have the accolades of your colleagues here. So I am curious to hear about what your role at the university is and how you are connected to this, because it was surprising to me. I'm hearing about this program that's going on at Bay State Noble.
Yep.
And then you're a professor.
How does that fit?
Yeah, how does that fit?
Yeah.
So what? And also a little bit about your background, because as I understand, you used to work at Noble.
Mm-hmm. Yep. So it does all tie in together eventually, but I did work at Noble for over 20 years before transitioning into academia. So I have a lot of experience with the Westfield community, with the hospital, with the area. I've been around for a while. But I also practice at Tapestry Health, which is another community organization that has several arms, one of them being harm reduction. And there I practice as a harm reduction nurse, taking care of people in the community that use drugs and helping them find access to safe resources.
That's interesting. At the university, you're teaching, you're working with aspiring nurses? Is that that's the program you're in?
So I oversee the nursing program, which is students training to become nurses or nurses
Oh, you
coming
actually
back.
oversee the entire program.
I do.
Wow.
She's very important.
Yeah, that's impressive. That's great.
So that's my day job, and so student nurses, and we graduate about 30 to 5 nurses a year, but we also have nurses in practice coming back to complete their degrees, and so we have a lot of students. And in that role, I continue to participate on a lot of different community organizations, one of which is the Bay State Noble Opioid Task Force, which was established quite a few years ago, but has done, a lot of work in this arena, and really where this project started from. Mm-hmm. So there's been a lot of discussion, in the past years about this vulnerable population, people who use drugs, and the barriers that they experience seeking access to good care for many reasons, shame, associated stigma. And so we know that there is room for improvement in the care that we're able to offer folks out of our hospital, out of our emergency department. And that's what we're here to do, to help bridge that gap for people who use drugs in the community and be able to help them navigate access to resources and different levels of care, but also be able to provide a welcoming environment that is non-judgmental, meets people where they're at that day, and doesn't apply the stigma that exists currently.
So are we talking about all drugs or just primarily opioids?
So we're talking about all drugs.
And that's opioids, is that, I'm assuming that includes cannabis?
It
or
includes any drug
alcohol?
you want to quantify. Alcohol certainly falls
Okay.
under that umbrella.
Cocaine, obviously.
Sure, sure.
And
Really-
also MDMA, ketamine. What is the one that's out now?
Xylazine.
Xylazine, which is particularly dangerous. But it really just, what Jess said, it's all drugs, all substances. It's not just opiates. Opiates kind of, I feel like, gets the majority of the attention, especially now. But in our emergency department, we help anybody coming in with any kind of substance use disorder, and typically a lot of them will go hand in hand. You'll have somebody who will use, a couple of different substances. So, we're prepared to help them in whatever it is that they need, whatever substance it is that
Okay.
they are currently using.
Do you see one type of drug being more abused than another, or is it equally distributed among all populations and people? Is it more opioids?
I would say, we see it all. So I think maybe when someone comes in and they've been smoking marijuana, sometimes we don't even know. Maybe we'll smell it, but we don't know. But if someone comes in after taking a lot of heroin, that's an opioid, there might be an issue. And what we're seeing, is people coming in unresponsive or whatnot. So there's a little more, like she said, attention given to the opioids because they're dangerous. And
Are they the most addictive? Do they have the highest level of addiction rates, opioids in particular, or?
There is a significant percentage of people who take opioids for reasons other than intended that become addicted, yes. But addiction in general is something that people I don't think there's a common understanding of what addiction is, and oftentimes there is the misconception that it's a choice or something that somebody could just stop doing if they chose to, or if they believed hard enough that they could. When really addiction it's a brain rewiring. It's a chemical imbalance of serotonin and dopamine and the brain chemicals that regulate our moods and our happiness and pleasure that need to be reset. And so that is true with all addiction, whether it be alcohol, opioid, what have you. And that is, I think that's the important concept that we need people to start to embrace and understand, is that it's a disease. It's a rewiring of the brain. And people need help until they can come to a point where they want to, stop or reset their brain or what have you. And it's not our place to judge. It's our place to accept and offer assistance where we can. Yeah.
And I'm just asking these questions because I honestly don't know.
Sure.
So, like, smoking is addictive. And some people seem to be more prone to addiction than others. So if you're prone to addiction, does that mean you're prone to all types of addiction, and those who aren't prone really could use and not be addicted?
I mean, I
Or is
guess
that
you
too
could
general?
say yeah. I mean, I would say yes and no. I mean, yes, I feel like some people are predetermined, or predetermined is not probably the best word, but an addictive personality, some people do have that, so it would make it easier for them to, use a substance, get addicted to a substance. But also that wouldn't, it also coping skills, depending on what level of coping skills you have and your support system, that plays into it as well. Just in and of itself, like having an addiction to one thing doesn't mean you're automatically going to get addicted to something else, but it doesn't help. But it also doesn't mean that just because I don't. What I'm trying to say, I guess, is that anybody can get addicted to anything at any time. Yes, there are definitely things that can make it easier for us to be addicted or become addicted, but this can happen to anybody. And that's another thing that I feel is really important for the public to know, because, I think not everybody, but a lot of people have kind of a picture in their mind of somebody who would be addicted to substances. And that's not always the case. There are doctors and lawyers and nurses and teachers and mothers, and, addiction is not picky. It can go after anybody. So that's really very important for the public to know, that just because somebody may look like they don't have a substance use disorder, or that they couldn't, it doesn't mean that they can't or they don't. So.
I need to back up for a second. So at Bay State Noble, you're in the emergency department, which we refer to on the street as the emergency room.
Yeah.
Is that one and the same?
It's one and the same.
Yeah, emergency room, emergency department,
Okay.
ER.
And so is that where both of you, that's where your place of work is, basically, in the hospital?
Tell them.
Yeah, it's one place of work. Yeah, I work. Yeah, I don't work there full time anymore.
Okay.
I worked full time in the emergency department for many years, but now I'm per diem, so I go in a few hours here and there.
Okay.
So I work elsewhere. I have, like Jess was saying, you had a daytime job and another job.
Right.
Yeah, we've got various jobs. So I've gone back to do more hours with this this opioid project. So.
Yeah, Sarah and I worked in the emergency department together for a really long time. And most recently, the past couple of years, we've kind of branched out and done other things. One reason, being emergency department nursing is very hard. And, it takes its toll on you after so many years.
I'm sure.
But also, too, I have found other avenues in which I can do this work as well. So I work at other places kind of doing the same work. So it's nice to be able to go and do many different things. It doesn't just have to,
Right.
Yeah.
But yes, the emergency department's our home.
So at the emergency department, you're seeing people coming in off the street that either bringing themselves in or being brought in through the ambulance.
Or families bring them in.
Or families, okay. When we talk about prescription drug use, that's the one thing I think that probably catches a high amount of press in the United States right now is, keep reading about, all the doctors were prescribing, the medical system said don't treat I was just reading an article on this, they don't treat the injury or the issue at hand, just feed it with drugs and that'll take care of it. But then that created this addiction problem that we have, and people are really struggling with that. So when you look at the use of prescription drugs, how does that fit into the world of illegal drugs? Is that a bigger percentage? And again, that's probably hitting people that you wouldn't expect to have a quote unquote drug problem.
Yeah. And you hear stories about people with addictions to opioids or heroin, things like that. They will say that this started because they were given a prescription for painkillers from their doctor. Certain pain medications are opioid medications and work in the body the same way as heroin does. So you get heroin off the street, you get your prescription from your doctor, but it's the same mechanism of action.
Still working on the same receptors.
Yeah, and so they're highly addictive. These pain medications, and there were many years that doctors were overly prescribing these meds and giving them out freely almost, and people were using them, and yeah.
Yeah, and then there was we stopped.
We stopped. Yes,
that
I
practice.
wanted to definitely mention that.
Abruptly.
But abruptly to the
Yeah.
point where we stopped prescribing the opioids. Doctors are now we have to be cognizant of our licenses and who we're prescribing to. But we didn't give people a fill-in. We didn't bridge that gap for people, and we have done them a misservice. And so people in the predicament that Sarah just explained have sought illegal drugs to be able to regulate their brain chemicals.
So they still have the issue going on. They just can't get it legally now, so they go to illegal
Right.
means to find it.
Yeah. And some of the prescription drug abuse is because of experimentation, and there's I learned about this from my students, and I was horrified. But there's such a thing as a farm parties that kids have, right? So you go into your parents' medicine cabinet and you grab whatever pills you can find, and you put them all in a big bowl at the party, and then you just grab.
That's horrifying.
Right. So
And see what effect
and see
you
what
get.
happens, right? And we know kids' brains aren't developed
Right.
fully until they're
Yeah.
27. So, there's a lot of facets to the problem with addiction and the problem with overdose and accidental overdose. All overdoses are accidental, but it's a very multifaceted problem.
Interesting. So again, the program that you have is, how is that designed? How is that funded? Is that external funding? Is there a time frame that operates under?
Yep. Yeah, so Senator Velas awarded funding to Western Massachusetts specifically for Westfield to utilize for projects like these. And so funding was allocated, and the project started in January of this year, and it will wrap up. Funding ends at the end of June. So it's a 6-month funding
Oh, it's pretty
project.
short.
It's pretty short. We've seen a lot of success in a short time and have been able to implement changes pretty quickly that have been well received. And I'm hopeful that we'll be able to continue finding support to carry on the work, because there's a lot more work to be done.
Yeah, addiction doesn't just stop because the program stops.
Yeah.
Right.
Yeah, we have a lot more work to do, but that is where the initial funding source came from, and we're very thankful for it. And the opioid task force really looked at what infrastructure needed to be put in place to get this work done. And the emergency room nurse manager said, I think Sarah and Heather really need to be a part of this. They're well respected among their peers at the hospital. They both have a background and specialty in this type of work. And, I think we really need to make sure that they're at the front and center of this. And so I think, a lot of stars aligned to be able to make this happen. I've been around for 30 years in practice and have always seen this as a need, and so it just feels really wonderful to be able to be marching in the right direction at this point.
So the program specifically, are you direct caregivers to people that are coming in off the street, or are you working with other staff at the hospital to help train them to become
So a little bit of both,
better
actually.
caregivers? And what does that mean by being a better caregiver?
So one of the main things that we're focusing on is in our emergency department, stigma, right? So that's like the first thing, stigma. We want people to feel comfortable coming to Bay State Noble Hospital. We want them to feel comfortable coming in and seeking assistance and knowing that, it's going to be judgment-free, and, we're going to do as much for them as we possibly can. So right now we're kind of in in the process that we're in now. We're working more with the staff to kind of engage them, educate them, get them really super excited about, you know, this work that we're doing. And so that's kind of like the first part of it. Going on behind the background, you know, behind all of that stuff too, Sarah's working on things, I'm working on things. Jess is keeping us in line while we're working on those things. And so it's eventually, my hope is to get this staff trained, you know, and also feeling supported. You know, we want the staff, this is hard work. This is hard work. And, you know, it's on top of already being an ER nurse and that being hard work, you know, it's to deal with, you know, a population that, you know, needs a lot of our attention, a lot of our assistance. Like sometimes that can be really difficult. So we want to make sure that the staff feel very supported, that they feel like they can come to me and Sarah and kind of either vent to us or ask us for assistance or ask us questions, whatever it may be, or ask one of us to meet, you know, with the person in the emergency department. And then also we are working on resources for the staff and the patients so that when somebody comes in looking for help, regardless of whether they're looking for a detox or they're looking for medication-assisted treatment, whatever it is that they want, we want to be prepared to say, here is the literature that we have, not literature, resources, and we can assist them in making those calls to get into those types of programs. So that's how we're starting. It's very much like staff first, and then eventually I want to do more bedside, one-on-one. I want to really get out into the community. I've kind of been trying these past couple of weeks. It's just been really hard with my schedule. But I want to go to community meetings. I would like to have the community coming, you know, into Noble. I would like to, you know, have meetings there and just, you know, meet these people. And again, like Jess says, like meet them where they're at. So, you know, we're just kind of using this grant money to just kind of do as much as we can do in a short period of time, and just help who we can help, and then, you know, we're gonna like kind of go from there.
Yeah, there's a lot. There's really a lot happening right now, and you are very busy. The two overarching goals for the program are to increase access to resources. And for like Heather said, for the community, that means one thing. For our staff, that means something else, resources in education or insights or what have you, experience, and to decrease stigma. So there's really only two goals. But so far, to meet those goals, you know, Sarah and Heather have been doing a lot of work in communicating about the project and getting out and making community connections so that when we do have somebody who needs to go to the next level of care, we can do what's called a warm handoff and actually send them to that, you know, detox facility or to Tapestry Health down the street and let somebody know they're coming or get them over there. And so a lot of that work is really, you know, just making contact with resources in the community, setting up meetings, getting to know people so that we have this network, and then also sharing with the staff that this network exists and who's in this network and what the resources are.
Right.
Because there's a real knowledge deficit right now as far as, all right, I have this patient, you know, I want to help them, but I don't know how.
Right.
You know, and so we're
Right.
trying to address all of those things and decrease the stigma.
Yeah, and being as supportive to, you know, the patient as we can.
So is the goal at Bay State Noble to try to get as many staff up to speed as possible? Because obviously you're not covering all hours every day, 24/7.
Right, right,
And
yeah.
so, you know, when you're not there, you're obviously very keen on this program. You're keyed into it. But when you're not there, is there a fall off in service or
Well-
awareness, and is the goal to try to get everybody else up to speed?
Well,
so
that,
that
you
they're
know, that's,
providing
you know,
the
where,
same-
yeah,
Right.
that's where the education that Heather was talking about, that's what we want to do with our staff. Just
Right.
share what we know.
And I will say the staff at Bay State Noble, they're
Yeah.
fantastic.
Yeah.
I mean, they're already doing this work.
Yes. Yep.
So it isn't, we're in no way like saying that,
Yes.
they really need all this education. They don't know what they're
Right,
doing.
right.
They're
Right.
wonderful. The staff there is wonderful.
Right.
We just want to give them the resources so that they know different paths of recovery. Like it's not all about, going from the emergency department to detox. There are many other avenues that you can take to get help. And so that it's common, when people present to the emergency department looking for assistance, the first thing we do is refer them to detox. But detox is not always the most appropriate thing for a person for multiple reasons. And so, and at that point, our nursing staff and the ER is like, okay, well, if you can't go to detox, I'm not really sure. So what we're doing is working on resources. So I'm working on a resource binder. I actually did not realize how much time this binder was going to take me, but I'm working on it's going to be sectioned off, and it's going to have areas for detoxes. It's going to have areas for medication assisted treatment. It's going to, like I said, there are many different things that you can do other than a detox. And I feel like when people come into the emergency room, they can feel defeated, right? Like it's not easy. It's hard, and to just be given a paper and be like, well, call these detoxes, and best of luck to you. It can be really, really. We can miss an opportunity there. If somebody is feeling defeated and they can't get into a detox, or they can't, get assistance, we miss that opportunity, of somebody who really needs the help, and them not getting it. So we want to, be a resource to say, like, here's all this stuff. So we're putting that together for the nursing staff, and hopefully that will just give more options, to the community.
And I will say, you're talking about your binder taking all this time, and it's true. Heather and I do have some experience in this area, but even as we started this project and going out into the community, I have come across all these new resources that I didn't even know existed.
Exactly.
So that says something right there. Like, and just that we could put this together in a book for people to use, for our staff to educate patients, share with families, patients, whomever, share with other providers.
Are the circumstances that people come in with who are afflicted with these addiction issues, are they really specific? So everyone needs to really have a tailor-fit direction of help that they look for, or do you say, if you've got an opioid issue, you do this?
Yeah.
Or has it become very
No.
specific?
It's very,
Heather's
very,
thing.
This is my thing.
it's very patient specific.
It is. It's very patient specific. And for many, many years, we didn't, these resources, have over the years, come up. So we didn't always have all of these things. And so detox always was, okay, you're here, you have withdrawal symptoms, detox. But what a lot of people don't understand, detox is a time commitment. Not only is it a time commitment, it could be a financial, depending on if you have insurance, if you don't. Then if you have co-pays, so we're talking about that. Then, we're talking about these individuals coming in. They're, like I said, they're doctors, they're teachers, they're lawyers, they're moms, they're brothers, they're sisters, they're caregivers. Right. So detox may not make sense for everybody who comes through the door. Because, I'll be perfectly transparent. I could not stop what I'm doing and go to a detox. I've got kids, dogs, husband, house, all that stuff.
And the stay at a detox is how long?
At least a couple of days.
So you're there for a few days, maybe, and then maybe longer to a step-down program.
And then
so
if
that's
you wanted to go to a step-down program
yeah. So you're
after,
Yeah, so
out of your
you're-
life for
It's basically removing yourself from everyday life.
Yeah, it's
And
it's a
everything else is going on.
hospitalization.
To your point, you've got real life going on.
Right.
That's-
Who
that's
watches
almost-
the dogs? Who takes
Right.
care of grandma? Like,
Right.
these are the things
Takes
that
care of kids.
right. Kids above everything, I hear that a lot. Well, I can't go to detox. Who's going to take my kids to school? Who's going to watch them? So in that particular case, again, we have to meet them where we're at. Detox is not appropriate. So what is appropriate? What can you do? And it's all about them too, and what they think that they're capable of. Because obviously detox would be the most structured choice. There's other choices that are not so structured that require, work on the part of the individual seeking the assistance. So, but still, there are other options other than detox. And do you want to say something?
No, you're doing a great job. And not everybody wants detox.
And not everybody wants
Yeah.
detox,
I
right?
was just having a conversation with somebody in practice the other day who has cut down their heroin use by several bags a day, and is really proud of that. And that's a good place for them to be today, And so high five, good for you. Like
Yeah,
if you
right.
feel good about that, then that's where you should be.
And what's good for you today
Don't let me
might not be good
prescribe.
for you tomorrow. So if you start, let's just say you start medication assisted treatment, and maybe that's good for you today, and maybe in a few days it's not going to be good for you, and you're going to be back in the emergency department. And you know what? That's okay. We'll help you find something else, because it's
not
not
a straight line.
It's not a straight line. It is not a one size fits all. It is peaks. It is valleys, and you could be doing fantastic, and you could have a relapse. It's all about like Sarah said, it's kind of I love this. It's like the path to recovery. There's a bunch of different ways you can get to recovery. Let's get you there, however that looks like for you.
So when you talk about detox, is that physically going away to a place?
That is an inpatient detox. So they would go. It's a voluntary admission, and there's various places around that offer detox. Hospitals. There are some. AdCare, a lot of those places offer detox. But again, it's a time commitment. They would go, they would check themselves in, and then they would be there at least a couple of days. And, while they're in detox, they go to groups, they meet with therapists, they may start medication-assisted treatment in the emergency, or in the detox if appropriate. But again, it's a time, they're in there for several days.
And what's the success rate with these places as far as people, when they come out, are they successfully able to live a normal life, or do they revert right back to their old behavior?
It depends. It depends on the individual.
And do you see a percentage? Are there percentages out there right now that they're
don't know
assessing and studying
numbers.
or not?
It would be really hard
Yeah.
to apply a percentage for what what Heather just said. A lot of it depends on the person. It depends on the social determinants of health and their environment, their access to resource, their access to support.
Support is huge.
It's
Support system.
we have a population that is either homeless or unstably housed, and that's a really tough environment to stay sober in. So it really depends on the person and the factors of their environment. But
Is this more male to female, younger to older, or is it evenly spread across all sexes, all age groups?
Yeah.
It's
every.
addiction's not picky. It's again, I don't know about
Racial
exact-
diversity doesn't matter. It's all.
oh,
It's everybody and anybody. I mean,
Yeah.
I don't have specific percentages. I'm sure there's got to be somebody who has maybe figured it out. But, we see this anywhere from young kids to, to seniors,
Yeah.
it's throughout the lifespan, and it's throughout different cultures, different races. It doesn't matter if if you have housing or you don't have housing. It's just, unfortunately, it's just across the board.
So I'm guessing that this program, you have set goals. Can you define those?
Yeah. So we really have two goals.
Okay, which you've already stated.
Yeah, well, to increase access to care and to decrease stigma.
Okay.
But some of the things that we're working on and have accomplished up to this point might be helpful to give it a little bit of context, right? So other than the community connections, which is huge, the nurses have started to establish a resource line, a telephone line that will go directly to them, either when they're available live or to be able to leave a message to have them call back, so that they can help with care navigation for folks, so that they do have access to Heather and Sarah in that respect when they're not in the building. They have organized, we held an event a couple weeks ago that was attended by members of the staff at Bay State Noble, as well as some community members. Really just kind of an awareness session, right? We had some folks, some guest speakers come in and help facilitate some small group discussion, and we were able to get a lot of feedback from that group as to what else is needed and additional needs for education topics, resources, things like that. We have, there is a nalox box outside of the Bay State Noble Emergency Department, which I'm just so thrilled that is there. So the community can go, it's not locked, you can just go and you can take out the resources that are available in it, which is doses of Narcan, which is the reversal agent for opioid overdose, right? And that box will just be refilled as often as it needs to be refilled. There's education in there as well and information for folks. We've done a needs assessment with physicians and have had some initial discussion about physician education that we can be helpful with. And we've also met with some other programs that are doing like work to get some feedback about, what is possible and where we can go in the future. So, over the course of 6 months, that's a lot of work y'all have done.
So where does it go after 6 months? The funding ends, and then what?
Well,
The problem doesn't
We're
go
hoping for
away.
more funding. So
Right.
if anyone's listening,
so I do know that hospital leadership and the opioid task force is really committed to continuing this work and letting the project continue to evolve and being able to support Sarah and Heather.
leadership at Noble is they're very supportive of our efforts, as well as any efforts that anybody in substance use disorders.
What is the funding specifically supporting? Is it your staff time, resources, publications? What actually is the funding being used for?
All of that.
Okay.
Yeah, we really have a very diverse budget as to what we're spending on, but being able to compensate, but we've also been able to provide a stipend for guest speakers and experts to be able to come and speak with staff, to be able to publish different types of education materials for the community. So it's, the money is being spent on a variety of things, all project related.
And does the money come into the university and it funnels through there? Is it coming through the hospital? Where's
Through the
Through the
hospital.
hospital.
Okay. And then who oversees that budget? Is that you or
It's definitely not me.
It's
you're
the,
just the care, right?
no, it's the community benefits office. It's the hospital. We don't directly oversee the budget. There's another
Okay,
Yeah,
another tier.
another
Right.
tier. So
So I wanted to ask you about, you called it the Nalox box?
nalox.
Nalox box.
Box.
Nalox box.
Yeah.
What is that specifically, and where is that?
So currently, it's hanging right outside the doorway into the emergency department, and it's. Have you ever seen AED on the wall?
Yeah,
Right.
yep.
So very similar. In the event that it is needed, or if somebody wants to have it in their pocket, anybody can just go and open that box up and take out the contents, which are doses of Narcan and how to use it, and some education on community resources. There is a stigma attached to asking for Narcan. Places like Tapestry Health you can get it for free without a prescription, but otherwise you do need a prescription. And so for some people, that's a barrier to actually going to have this life-saving drug. So the Nalox box makes it possible for anybody to just take that Narcan and have it on them.
Is
in
there
the event
like
that they
just
need
one
it.
dose per person in it, and then you refill it, or are there multiple
There's,
doses?
I think, four.
Yeah, there's a few doses in there, and then
It's-
it's refilled on a regular basis. Actually, Tapestry Health have an office now in Westfield. I think they've been there maybe about a year, and their program actually refills for us. So they check it on a regular basis, or we can let them know that it's we need more doses, and they
Do
refill.
people tend to take one, or will they take all four?
I have not seen what's been taken out of the box at the hospital, but I have asked that question to some of our community resources, and I've been told that they don't see that. It's very respected, this box on the wall. People will come by and maybe take a box if they need it, but they'll leave the rest there. Like,
We have the boxes all throughout the city of Springfield, and that's
Oh, really?
Same-
Okay.
yeah, it's very respectful.
And what is that? What's in that box?
in Narcan.
And what is
Or-
that?
okay.
And what does it do?
Yeah,
How do you use it?
Narcan is the reversal agent for an opioid overdose.
Okay.
So if you've taken too many opioids, you want this other drug to kind of counteract those effects and kind of bring you out of that. It is a nasal spray.
Okay.
That is very easy to. You can just look at the bottle itself, and you can see how you're going to spray it, and it gets sprayed into the nose. And it's wonderful to have it. That you can get it for no cost through Tapestry or through one of these Nalox boxes, and because people that use opioids or know somebody that uses opioids or whatever, I carry a box with me around just because you
In
want to
case you
have
need
that
it.
if you see
Okay.
somebody
Right.
Unresponsive and you think maybe the reason is a opioid overdose, you can take that drug right there and spray it in their nose. It's not going to hurt them.
So it's ingested through the lungs? That's how it gains access to the
Well,
body, or
Mucous membranes, I guess, right? Because if someone's opioid overdose, they're not breathing. So it's not going to go
they're
all
not
the way.
breathing.
Yeah, they're not going to
Oh,
go.
I see. And does it have an instantaneous effect?
Yes. So Narcan works very, very quickly, but it also can wear off quickly. So usually they'll need more than one dose of the
Nasal.
The nasal, thank you. You can, Narcan is available other ways too. We use it in the hospital. We can do it either IV push, or we can do a drip. We can even, give it to them in an injection. It does work quickly.
So police, fire, ambulance, EMTs, they're carrying this with them pretty much every day
Yeah.
on their person so that
far
if
as
they
I
have
know,
to
yeah.
administer it, they do.
Yes. Because the good thing about Narcan is that if you give it to somebody and that's not their issue, it won't hurt them. If you go and find somebody down, you're not necessarily going to know if it's because they've overdosed or if they've had a heart attack or something like that. So, if you have Narcan and you use it and it's not because that person, has taken too much or overdosed, it's not going to hurt them. So that's the good thing about Narcan. Not only is it extremely useful and, works well, it also won't hurt you if given to you. And that,
Oh, it won't, okay. So if you have someone in your family who is struggling with drug abuse and you suspect that they're really overusing and have an addiction problem, are they recommended to have Narcan? Do they, or
Yeah.
in their presence or in their home?
Yeah.
Yeah, even for when there's not an associated risk for that reason. I mean, my parents are older, and my mom had surgery recently and was prescribed narcotics for pain relief, and Narcan.
Yeah.
And my parents were shocked and horrified that she would get a prescription for Narcan, and it makes sense. You get confused, you take 2 pills instead of 1.
or if you don't know how it affects you,
it's just a safety.
And I'm seeing that on many, many medication lists these
Yeah.
days. The doctors, when they give a narcotic prescription, they're also giving the Narcan.
'Cause
Is that right?
You never know.
So let's talk specifically about seniors. I am gracefully moving in that direction. I already am a designated senior. And what I find about our age group is that we are now in the surgery class. We're having hips replaced, we're having this done, we're having, it's like, oh my gosh, what happened to my body? And so you end up getting, pain prescriptions. Now, I've always tried, I've had my share of surgeries in the last few years. It's like, oh my gosh, what happened? So I always try to do everything through aspirin or Tylenol, that kind of thing, because the strong drugs just scare me, so I try not to use them. But let's talk about that for a second, because pain is pain, and you're also, taught to, control pain, or don't let it get ahead of you, and use the drugs to really help stabilize that. But for people, especially seniors, what are your tips on how to ensure that you need to have it, but how do the fear is that it's going to become addictive, that all of a sudden you become addicted.
That's huge.
And
Yeah,
how
yeah.
quickly is that,
and that's
does
the
it create
problem
addicted?
with all of this.
Hear that all the
With looking at the substance use disorders and the opioid epidemic and all of that. So I mean, that's wonderful. We're doing a lot of great work. But then on the other hand, I think it did scare people a little bit into being afraid to use them.
Yeah.
So opioid pain relievers have their place. They are, they were made for a reason, and they do work very well for pain. We hear that a lot in the emergency room. People come in and they're like, oh, I'm in so much pain, but I don't want to take my Percocet because I'm afraid I'm going to get addicted. That's not how addiction works. If of course you need to be careful, and so one of the first things I tell people is, well, if you're worried about that, then, start with your Tylenol, start with, Motrin, Advil, Aleve, anything, if not contraindicated because of your surgery, start with that. And if that's not helping you, then you can take the Percocet. Start with 1 Percocet. If you want to start with a half a Percocet, have a half a Percocet. And then maybe it's only that one time you might need it. Well, then maybe, but maybe you might need it again later on. And so I just tell people, just be mindful, be cognizant of when you're taking it. Take it, if when you're supposed to take it. Don't take too much of it. Don't take it, if it's supposed to be every 4 hours, don't take it every 2. and I just reassure people, opioid pain relievers have their place. Like, if you have surgical pain, the surgeon does not want you to have pain, because then that inhibits your healing. So, my advice to people is just don't worry about the piece. Let's worry about controlling your pain, and then, and go from there. And just the fact that you're taking it does not automatically mean you're going to get addicted to it.
Sarah, you were going to
I was just going to jump in and say, when you were talking about the surgical pain, these most often the prescriptions I see that when someone comes out of surgery or needs a pain medication for something, they're really only for 2 or 3 days. They're not giving them a week's supply or more. And so everything that Heather just said, start slow and, try it. If it works, great. If you don't need it anymore, great. But if you are using it, it's only for a few days anyway, as long as you're using it correctly.
Right.
And for people that are scared that they might become addicted, it's the benefits, I think, when you're having pain like that, kind of outweigh the risks. There's really...
So, to become addicted, can you get addicted on a small amount, or does it really take repeated usage at a fairly high level? Where does addiction start coming in? When do you start feeling addicted? Or is that all over the place?
It's all over the place. So tolerance means you need more and more of something to get the same effect. And that can happen outside of addiction. I mean, that's its own phenomenon. But addiction starts when people start using the drug not for its intended use. Because the drug does play with the pleasure receptors in our brains. And so if we're taking the drug to make pleasure in our brain rather than to relieve pain, that's the difference. That's...
Yes, you could do that with 1 pill, or you could do that with 120 pills. It's just it's different for everybody. And there's no one thing that can say like, oh, don't take that Percocet because you might become addicted.
Yeah.
We just tell them to just use it carefully and use it for what it's intended for, and to follow the prescriber's instructions.
And there will still be people that won't use it, and that's okay because they are afraid or for whatever reason, and
But they are giving in smaller amounts, like Sarah said.
Yeah.
It's not, back in the day you would have certain, I can even remember past surgeries that I've had, within the past 5 years where I got discharged, and I got 60 tablets of Percocet. Then when I had my C-section, 12 years ago, I got 60 tablets. They're not so much doing that anymore. They're giving a very small amount, and that's just to get people over that hump that, after you have surgery. But typically when you're a couple of days post-op, this is generally speaking, but when you're a couple of days post-op, your pain starts to go away. So, at that point, if you're still having severe pain, you would be following up with your doctor anyway. And so then, that it opens up space for a conversation like, oh, doc, I still am having this horrible knee pain, but I'm out of my Percocet. So then that kind of, alerts the doctor like, okay, to kind of think about it. Is this person, do they need more pain medicine, or do we need to maybe try something else? Maybe, more surgical intervention, PT, anything like that.
But seniors should not be scared off from the use of pain medications. If it's been prescribed because they've got an issue, and it's there to help them address that issue, and they need to use it as intended. And if they use it that way, they should be okay.
And to always call, their surgeon, their doctor, whomever, if they have questions.
Yeah.
Because there's, people
And
have questions.
Yeah, and if they're that concerned, it is always okay to take, less. Not all medications. But if, like I had said earlier, if they, wanted to take the tablet and cut it in half, that's okay. Cut it in quarters. I remember my mama used to cut them so small. So it's perfectly okay.
I think seniors should know it's a tool in their tool belt when they're dealing with pain, right? And there's a lot of things that can alleviate pain, including movement, including heat, including cold, including Advil, including repositioning.
Yep.
And if we're trying stuff and it's not working, and you have that accessible, then it's very useful for treating pain. So nobody should suffer in pain.
No.
If they should really work with their care providers to make sure that they have a plan in place to meet their needs. Nobody should ever be living in pain.
Because increased pain leads to decreased movement, right? Which, we know in seniors is very, it causes, when you're not up and moving around, you're at risk for a lot of other things. First of all, increased pain because you're just kind of sitting and, your joints, so increased pain there. Then we have to worry about things, blood clots, pneumonia, all those things, constipation, all those fantastic things from just kind of sitting there. So if taking your Percocet means that you are going to be able to get up and go through your regular daily activities, it's going to benefit you in the long run, versus just kind of living with the pain and just sitting there or laying there and just kind of hoping it goes away, because then you can get all sorts of other things that are not fun at all if you don't.
That's a great point. That's interesting. So in the work that you're doing at the university, you're working with aspiring nurses. How is this being communicated? You're teaching this. How has this become a part of your curriculum?
Yeah, so several different ways. Our students have become more involved in these types of discussions over the past several years. We have brought some of the tools available to the students. So, for instance, Senator Vilas Earmark a couple of years ago went to support the production of a documentary that Tapestry Health produced. And so we've brought that documentary to students as a learning module and to have discussion around all of these topics. We're seeing students more and more want to start their practice outside of the hospital, which is a trend that is new. And so we have a lot of students that are interested now in careers in community nursing, but specifically mental health and substance abuse nursing, which is a different trend. And I think it's because we have, brought the conversation to the table, and it's hard not to see the need that exists out in the community. But we had one of our nursing students at the event that these guys had recently for the community. She was one of the participants there, along with her mother, who's a nurse in the emergency department. So we do a lot with our community partners at the university. We have students that rotate through Bay State Noble. We have students in the emergency department at Bay State Noble. We're very interconnected.
We love our students.
And so there are public forums here in Westfield that address this, that people can come to, or are they really just more professional oriented for staff? And
We had one professional, I wouldn't say professional, but one sort of kickoff event where we invited community to attend if they'd like. But, Heather's vision, and I concur, we all agree, an ongoing community conversation is something that we would like to see happen. Tapestry Health has actually started some of that in the community, but we really feel like the hospital could be a kingpin and as a centralized leader in the community and a stakeholder resources to provide the context for some of those conversations and to host them. I think it's going to take a lot of conversation and continued awareness for folks to really get on board with the work that we're trying to do and to learn and to protect themselves and keep themselves safe and their loved ones.
I'm guessing that at the end of this, or maybe throughout this whole program, you have to be able to show tangible, measurable results that, yep, the money is being well utilized and it's having a tangible impact? How do you measure this? Because to me, it's pretty subtle, you know, it's more long-term. It's not like, well, we turned this from black to white, you know, it's measuring behavior and
Yep. And
personality changes is really hard.
yeah, in the course of 6 months, it's almost impossible
It's
to
a
show.
drop.
Yeah, to show
That's how I look at it.
long-lasting change. What we are able to demonstrate, though, is through feedback that we got at the event, we have been able to determine that there is an interest in this work. There is a commitment towards engaging for further engagement to try to make this continue to happen. We'll be able to measure the amount of Narcan doses that have been utilized or at least taken by the community. We will be able to provide a tangible resource list, binder, something to be able to show that we've got access, increased access. So there are some deliverables that we're able to show in a short amount of time. Yes, we would really love to look at the long-term effects of this and see what kind of impact it has on the mortality of the community, and whether we can get some people connected to care that might not have otherwise been able to do so, and some of those more long-term goals. But yeah, this is a drop in the bucket.
Yeah. The good news is the work that we're doing now, grant or no grant, if they say, tomorrow, okay, we're not giving you any more money, we've already put a lot of stuff into place that's going to help Bay State Noble, like the nalox box and then the resource binder, and something that I wanted to mention that I know that Sarah is working on too is support for families as well. Mm-hmm. There's not a lot of support out there for families, and in my experience, it's been, people don't typically, families don't, moms and dads, they're taking care of, their child or a grandchild or whatever. I feel like they feel very stigmatized, like to go somewhere and say, I have a child who has substance use disorder. So we want that to be like a normal part of conversation. Like, it's okay to say, it's okay. It's no different than saying my daughter has high blood pressure. You know what I mean? So, but there's not enough support out there. So, Sarah's working on a lot of that to try to put those things in place too. So bottom line, even if we didn't have another dollar of fund, which we're very grateful for the funding. I don't want to make it sound like we're not. We're very excited, and we are definitely going to utilize every penny that we get. But if the grant were to stop today, the work that we're doing now will hopefully just, stay in the emergency department and just be passed along.
That's a good point. It's foundational.
Yes.
So people that need help, either for themselves or for their loved ones or friends or people that they know, what is their best course of action? Is it to call Bay State Noble? What is their best course of action to find help for those who need it?
I mean, I guess it depends on the individual and what it is they're looking for. If they're medically ill, going through withdrawals, probably the emergency department would be their best bet. But there are a lot of other, resources and programs out there. Like Jess said, there's Tapestry. There's phone numbers that you can call and get information. Like we talked about earlier, the designated phone line. We're going to hopefully have that line again. It's not going to be something that somebody's going to be able to answer 24 hours, but it will be good for somebody to call to be able to get in touch with one of us, leave a voicemail, and we can, assist them that way as well. And it was, we thought about maybe doing cards, when somebody comes in, and sometimes we have people coming in and, they've had an accidental overdose. They've been given some Narcan and they're really just not pleased to be in the emergency department. So we try to do work with them and try to see if there's any way we can help them. But sometimes they're angry and they don't want anything to do with it, and that's okay. But I would love to be able to give them something, to say, like, here's a card with a number on it. Tomorrow morning, if you wake up, 2 weeks from now, if you wake up and you want our help, please call. So, they can get help in a bunch of different ways.
I think the best advice that we can give is to have people try to be as honest as they can with the information that they need to share, and share it with people they feel safe with. And hopefully that's a care provider or somebody that can connect them with care, because there are resources out there, but they're very difficult to navigate. Ideally, if we can get our dedicated line down, I think that Heather and Sarah will be able to help people with that navigation in a very meaningful way. There are other resources in the community. It's hard. It's a tough navigation, but people shouldn't feel ashamed. So,
No, we want Bay State Noble to feel like a safe place. Like we want people to maybe, if we're not going to, change their life right then and there, at least they know they have an ally. They can, come in, see a friendly face. Another thing that's very, very, very important to me and, in doing this work is I fully believe that, we have to meet our basic needs before we can do anything else. And what I mean by that is, if you don't have housing, you're sleeping outside in the cold and the rain, you're hungry, you can't feed your children or clothe, whatever it is, you have to meet your basic needs before you can do anything else. So, I want to pass that along too, and let that be known. Like, if you need a meal, we'll give you some snacks. We'll help you find, food. We'll get you connected to people that can help you find food or find shelter or find clothing or something. And then we can talk about what recovery is going to look like for you. Because if you're starving or cold or worried about your children, you can't recover, or you can't recover, to the fullest extent. So, we want to work on meeting those basic needs, to fill in those blank spaces so they can be able to just focus on their recovery.
Well, this has been an interesting topic. It's unfortunate that we have to talk about it, but we need to talk about it, and we need to address it. There's no question. And I want to say thanks to the three of you for coming in, especially the two of you. You're on the front lines dealing with this every day, and it's important for people to know that there's a place that has caring, giving, loving people like yourselves that are willing to help them address it. There's no shame in it.
And we would love to go visit the senior center.
Yeah?
Yes.
We would love to have you at the senior center. Tina Gorman will take you with open arms, our executive director. So, Sarah, any final thoughts or words from you?
I appreciate being given the opportunity to be here and speak with you. And this is something that I'm very excited about. I really believe in, and I hope that we can really make a difference and help some people out.
Yeah, I think you're already doing that. That's great thoughts. Thank you. Heather, what about you?
I mean, I'm basically the same. I love this work. I love the city of Westfield. Like I was born and raised here, and I've been doing this kind of work for a long time. And I mean, I'm really excited about it. Most days I'm like, oh my god, like it's crazy.
That's okay.
It's wonderful. Like, and I am beyond honored that our manager at the emergency department felt that he could ask me and Sarah to do this. To me, that's the highest compliment.
Yeah.
Well,
To
yeah.
be chosen,
You
to
should-
be asked
you
to do
should
that.
feel
So
honored. Yeah, good for
I'm
you.
appreciative of that. I'm appreciative of all of this. I think Bay State Noble is a great hospital, and so I'm just I'm excited and I'm grateful to be here too. And
Wonderful.
yeah, thank you so much.
And Jess, final words from you.
It's tough to top what they just said. But it's a gift to be able to do this work and to work with these nurses, and it's a project that's just really meaningful to me and feeds my soul, that we are able to help some of our most vulnerable people in our population through the work. So thank you for having us and spending some time with us.
That's great. So our topic today has been opioid issues and how the grant-funded program in the ER at Bay State Noble Hospital has been addressing it. Obviously, they're doing a great job, and if there's one thing I can say is they need more money. So let's keep this program going. 6 months is a drop in the bucket. It's a nice start. But really, 6 months, you don't even have time to really fully address all the issues and then determine all the avenues of outcome that you want to put in place and how to address it. But today's guests today have been Jessica Holden, Associate Professor and Executive Director of Nursing and Allied Health at Westfield State University, and Sarah Warren and Heather Colon, Project RNs, who are the lead emergency department nurses at Bay State Noble Hospital. I want to say thank you to the three of you for the great work you're doing. Know that you're making a difference. I'm sure there are days when you say, why am I doing this? But you know what? I've always said, if there aren't those kinds of days, then you're not in the right kind of work. Because overall, if the bulk of your time is spent feeling like you're really truly making a difference and knowing that there are times when you're going to be stressed out and you're going to be asked to do things and you feel like you're not making progress, but overall, if you feel like you're really making headway, then you're in the right kind of work. And as I listen to the three of you, you're dealing with everyday issues. You're dealing with the future, and I love that. I've been reading about nursing care and the huge exodus that's starting to happen, and
That's
you know,
a
both
whole
from
nother
the
show.
That's a whole nother show about its age, it's about stress and lack of support and everything else that's going on in your profession. It's a huge exodus, and the fact that people are really concerned about how many are coming in to address those that are leaving. And thankfully, we've got programs like yourself at Westfield State University, which is doing a phenomenal job to really create those new resources to the future. But on behalf of Ken Stomsky, I want to thank you for being in to fill in for Pete Coles today, who is away, but Ken Stomsky's done a great job producing the show and making sure that we're in a position to be able to share this with our viewing audience. I am Harry Rock, and on behalf of Westfield Council on Aging Presents and Tina Gorman, Executive Director of the Westfield Senior Center, I just want to say thanks. Have a great day. We'll see you on the next show. Thanks.